So I thought we'd start with a quick trying to figure out what we know about TB and dispel some of the myths. And so I know it's been a long day, but if you can, let's participate in this for this last session. So TB is caused by a virus. Yes. Oh, it's off to a great start. That's excellent. TB is in fact caused by a bacteria, Mycobacterium tuberculosis. TB can be transmitted from person to person through sharing, touching, or sharing plates and cups. Yes. It can be transmitted through singing. No, it's true. TB is actually spread like the common cold. There are respiratory droplets which are in the air, and that's how it's actually transmitted. And it can be through coughing, sneezing, talking, laughing, singing. A fifth of the world's population is infected with TB. Actually, it's false. 1/3 of the world's population has TB. So 2 billion people on Earth have TB. So they have the infection, latent TB. It's not actually the disease. Everyone who's infected with TB will eventually fall sick and die without treatment. Yep. TB is actually curable. TB is preventable and it is curable. With the first-line treatment and you complete it, most people will be cured, 96, 97%. And for those who are not HIV, who do not have HIV infection, there's only a 5 to 10% chance in their lifetime that the latent TB infection will become TB disease. People living with HIV are 5 times more likely to fall ill from TB than someone who is HIV negative. Actually, it's false. They're 50 times more likely to develop TB. And in actual fact, TB in someone who is HIV progresses HIV, and in someone who has HIV infection and they get TB, it becomes worse. TB is preventable and curable? Well, I answer this, yes, it's true. TB is treatable and curable even in people living with HIV, and it's actually 96% curable in people who complete treatment, and that is identical to the rate of cure in people who do not have HIV who complete treatment. However, the mortality rate is much higher in people who have HIV. It is preventable. WHO, the World Health Organization, has guidelines on the various activities countries can do in order to stop the progression of TB in people with HIV. They call it the 3 I's. So in people living with HIV, intensified case finding. This is actually basically being proactive, going out to find people who have TB. When someone comes into an HIV clinic to see if they have TB or not in each visit. Infection control. So we know that now it's coughing, singing, it's like the common cold. So what happens when everyone's sitting together and there are no open windows, there's no sunlight, we don't have cough etiquette, so coughing into your sleeve, that sort of thing. Those are the things we need to think of to implement. And then, of course, isoniazid preventive therapy. We call it IPT. And with IPT, you can give this to people living with HIV, particularly in high burden in countries that are high burden. And for the time they are on IPT, they will not get TB, or well, it prevents them from getting TB. So in 2010, there were 8.8 million cases of TB in the world. 1.1 million people died from TB among HIV negative. And in HIV positive people, it was 350,000 people died unnecessarily last year, in 2010. So HIV and TB actually form a lethal combination. And in fact, we've heard over this morning, Dr. Anthony Fauci from the NIH, he said it's a marriage that is horrific. The two diseases work so well together in progressing the disease, each disease in a person. And yet, we see governments where the HIV program and the TB program don't even talk to each other. So if we can have such a great marriage of these two diseases that turns into something so negative in death, why can't we actually have the two programs working together in countries? And this is a question, as media, needs to be asked. And at least 1/3 of the 34.2 million people living with HIV have TB and are at greater risk of it developing into a disease. As we heard from, I think, Gustavo, TB is the leading infectious cause of death in people living with HIV, and almost 1 in 4 deaths are attributed to TB in people living with HIV, and it is the most common presenting illness. And yesterday I was at a session, and we heard from a young woman in Uganda, and she had TB 3 times. So if she had been put onto IPT early on, when she was found to be HIV positive, there's a great chance she would not have gotten TB 3 times. And you think of the effect, she lost her job because of the stigma on her family, economics, and so on. It's huge. So there are 1.1 million HIV-positive new TB cases globally in 2010, and 82% of this was actually in sub-Saharan Africa. So we know this region has an enormous problem. And multi-drug resistant TB is resistance to some of the first-line anti-TB drugs. And this is a problem that's growing at a huge rate. And we actually heard in India last year, early this year, about what they're calling it a totally drug-resistant TB. We don't know the name of it, but it's now TB that is resistant to all second-line drugs. TB is preventable and curable, and it is usually treatable in people living with HIV. There are lots of programs that we need to accelerate and scale up in order to actually reach universal access. So I wanted to tell you about the power of advocacy with HIV and TB. I mean, in HIV, the epidemic began 25 years ago. We had a history of strong political activism. Almost, rapidly we had drugs, we have new diagnostics, and they're coming out all the time. We now have a rapid test on a finger prick or saliva, which gives you a diagnosis in minutes. We have dozens of new drugs, and they continue to come out on the market. We have a huge research budget for HIV. And yet, if you look at TB, which is a disease that's over 1 million years old, we've actually found TB in the mummies in Egypt. And it's only recently that they've adopted activism. It's only recently that we're starting to see some new and slow progression in the terms of drugs and diagnostics. But the gold standard for a diagnostic is over 120 years old. And this means that it doesn't work very well in children, and it doesn't work very well in people living with HIV. Long delays, which mean that people's disease progress to a point where they die before they even know what their disease is. And we haven't had any new TB drugs in 40 years. The global research budget for TB is appalling. It is so small, and this is something that we absolutely need to talk about, particularly at this conference. You can't really, this didn't come up, but I just wanted to show you, on the left is malaria and TB from 2,700 before the Common Era, and then HIV from 1980. And you can see in HIV how rapidly we've got drugs, diagnostics, drugs, diagnostics, drugs, diagnostics, and then in TB, it's been from 1900 to 2010, and you can see how we just don't have what we need. However, we have had a year of progress in TB. So in vaccines, they've seen 2 prime boost vaccines in phase 2B. Diagnostics, we've heard about Gene Expert, which has now been scaled up globally. There are other molecular diagnostics in the pipeline, but we still don't have what HIV has in terms of a finger prick test, something that you can find out your diagnosis in 7 minutes or under. We do have new drugs that are coming out. 2 new drugs we're very excited about, delamanid and bedaquiline. These are now being filed with the US FDA. And a new latent TB regimen has been approved. And we're looking at now combination studies. So what is the vision? I mean, for a vaccine, we want something that is safe, long-lasting, stable, easily administered. You know, polio is so easy, it's a little drop in the mouth of adults and children, and something that will protect against pulmonary and extrapulmonary TB. In diagnostics, we want the point of care. We want something that can be used in remote healthcare facilities around the world. Something that is fast, it's sensitive, it's specific, it's affordable for people, and it doesn't need a lot of training for people to utilize the test. Something that works in children and people with HIV is absolutely needed. For the drugs, we envision drugs that are safe. I mean, if you think about being on antiretrovirals, then you're going to be on TB drugs, and it's a massive amount of pills for people to be taking every day. So we want something that's safe, that has a shorter course, it's a low pill burden, easy to tolerate, so there are not a lot of side effects, more effective, especially around drug-resistant TB, something where we have pediatric formulations right away, and is safe and effective with antiretroviral therapy. I just wanted to show you the total TB research and development funding from 2005 to 2010. And as you can see, in 2010, though it has increased a great deal from 2005, it's still only $630 million. And according to the Global Plan to Stop TB 2011 to 2010, we actually need around $2 billion a year in TB research and development. And you can see we're not getting that at all, particularly in new drugs, where we're only spending $230 million, and we should be spending $740 million. So the call to action, we need to focus on TB diagnostics as a gateway to effective intervention. We actually also have to really try and get our funding for R&D increased. We need a focus on faster approvals for TB drugs. And one of the most important ones, get people on ARVs as early as possible. We should be able to get people on ARVs when they know their diagnosis, regardless of CD4 count, because we know that one of the best preventions against getting TB is to be on antiretrovirals if you have HIV. So we have a declaration called the Zero Declaration. And basically what we're saying is after 2015, when we need to have a new strategy, we want to see a world where we have 0 TB deaths, a world where we have 0 new TB infections, and a world where we are able to prevent and cure TB in people living with HIV. There is absolutely no reason for anyone to die of TB in our world today. It's only a lack of political will. And every country in the world has the potential to do this. I mean, if you remember when we had the 3x5 initiative, everyone said, oh, this is impossible, we're not going to be able to do that. And yet we did. Granted, it was 2 years later, but we achieved the goal because we had mobilization around it. And so we're encouraging people to sign up to the Zero Declaration in order to get a mobilization around this new campaign. And as Nelson Mandela said in 2004 at the AIDS conference in Bangkok, we can't fight AIDS unless we do much more to fight TB as well. And we're seeing this on a daily basis, particularly in sub-Saharan Africa. If he said it in 2004, we should say, what have we done since then to actually achieve this? And we need to challenge those in government, in places of power to do so. I just wanted to also mention that tomorrow there's going to be a talk show about TB and HIV and called Protecting the Vulnerable. It's going to be streamed live at 12 p.m. tomorrow, and maybe Coco, you want to just give some details if people want that. This is Coco Jervis, who works at Treatment Action Group as well. And there's also going to be the We Can End AIDS mobilization on July 24th, where we're encouraging everybody to come out. So if you can also publicize that, that would be wonderful. One of the best resources that you could utilize is tbonline.info. And this is a website put together by the Global Tuberculosis Community Advisory Board. And they have amazing information that you would be able to get access to. Finally, we do have copies of the Zero Declaration for everybody and a press release about our new pipeline report. So we also have copies of the pipeline report. This is a report that Treatment Action Group and iBase put together every year, which outlines what's in the pipeline for drugs, diagnostics, and vaccines for HIV, for hepatitis C, and tuberculosis. So I hope you get to grab a copy of this on your way out as well. Thank you so much for your attention and for staying this evening.